there's no need to introduce Professor Vindare. He's been the editor of the spinal cord for many, many years, and he's the president of the East Coast of International Spinal Cord Society. We could go on and on and on with everything he's done. So I better...
Don't. Yeah, thank you very much. Thank you very much. I'm going to try to tell you a little bit about, in my opinion, another very important topic, and it is bladder care. I can remind you the not so recent history, but it is the history. Okay? And we have seen it, we have read about it, that the urorenal cause of mortality used to be half of mortality in the 1960s, that it went down to 3% and continues to go down, not because the patient have changed, but because the approach has changed. But still, there is an increased risk of renal failure if you look into spinal cord population or general population. So it is better, but not disappeared. The standardized mortality ratio you have based on urological things is still at this date about 10 times higher, and then septicemia still about 170 times higher than you find in the general population, most of it related to urinary tract. So we still talk about a topic that needs, for all kind of aspects, quite some attention. Also, causes for readmission. The leading cause for rehospitalization is skin problems, other cardiac problems, but also a lot of diseases of the genitourinary system, including urinary tract infections. So you have there a clinical entity that is really worthwhile to look into. What did we gain in the last decades? Knowledge. And the knowledge about the urinary tract has been quite interesting. While you have tendency perhaps to look at the kidneys, which is extremely important, try to go a little down and look at the bladder, because kidney function greatly depends on bladder function. So the main thing to look at is actually how the bladder does it. And what should we look at in the bladder? The pressure. That's how simple it is. What pressure development is there when the bladder is filled, when the bladder is emptying? And you will know that, perhaps you know, if you're really in this topic, that by sort of a rather ancient publication already, and not in spinal cord injury, but in children with meningomyelocele, it was shown that 40 centimeters of water was accepted as the limit safe pressure. And this is no surprise, okay, because just the higher pressure that the kidney and ureters can develop. So if you go higher, it will block, okay? If you go higher, it will break the valve between the bladder and the kidneys. But it is just too simple. Okay, to look at 40 centimeters, there's much more at stake. For instance, what do you think is the worst scenario? You see here ABC, you see the limit of 40 centimeters, you see the filling from left to right, and this is one, this is the other one, and this is the other one. There's a time factor. And I'm not going to discuss which might be the most dangerous one. I leave it up to you, okay? It's actually easy because it's C, okay? That is much more dangerous, but that clearly shows that 40 centimeter is important, but not something that you can look at alone. Concerning the urological rehabilitation and bladder care, the expectations are different if you look at different players. For instance, the rehab team, we say, oh, we have to keep the kidney safe. But much more important for the patient and the relative is we need not to leak urine, okay? And the kidneys are safe, okay, yeah, that's what you say, that's fine, but it comes rather a little later on the list. And health economists would say, what we need is the most optimal treatment and the lowest price to pay for it. Okay. So you see the expectations and the goals are different. But whatever the goal is, let's not forget that the bladder management starts from minute 1 after a trauma, and that it can, in the first weeks after an acute injury, often determine the lifelong outcome. And I have professionally been not in many conditions that I felt such a despair than when I got a patient for rehabilitation from intensive care with an infection of the urinary tract that could not be cured again. Okay? So it just took a couple of days, but it was lost, okay? Because there was no good treatment in this acute care, which in most cases there is a good treatment. What do we have then? As already mentioned, when you have your spinal cord lesion, you go, the spinal structure go into spinal shock. That doesn't mean that there is nothing happening, but there is no contractility in the lower urinary tract. So what we have to do, as the bladder cannot defend itself, one has to avoid overdistension and infection. Okay. And we need bladder drainage. There is nothing you can do about it. Okay. We need it quickly and we need it properly. And in most cases, it will be in transurethral indwelling catheter. In some, we'll put a suprapubic catheter. What we try to do after this period is get rid of these indwelling catheters as soon as possible, sometimes after 1 week, sometimes after 3 weeks post-trauma in those who are stabilized surgically, and move into intermittent catheterization. Is this the best? I don't know. It depends on your situation. Okay? It's perhaps not always possible, but I know it is good. That's different. Okay? So if you look at catheterization, I'm not going to develop it because there are enough specialists in the room. There are rules. And if you follow the rules properly, your results will be better. If you just buzzle around with catheters, you must be sure that there will be a lot of complications because in basic, it is very dangerous. Okay. Okay, we are on drainage. What we have to do now is make a proper diagnosis of what happens in the lower urinary tract. And that is looking at different things. Who is this person? What is the lesion? How does it affect the urinary tract? When has it happened? For instance, is it a man or a woman? That will change our approach. Okay? Is it a young person or is it a very aged person? That will change. The AIS lesion. The previous history, the social situation and quality of life seems a very long list, but actually that's what we know. Okay? The moment we approach the patient, we will have all this information easily. And you will agree with me that all these pictures you see of patients with spinal cord injury, they are all different. So the approach will be different. Okay? It's an individual approach, and that's also something which is important. Determining what you have to do depends also on where the lesion is. And if you have a very high lesion, or a lower lesion, or a peripheral lesion, what comes out in function of the lower urinary tract will be different. So what the lesion is neurologically and how it affects the urinary tract is important. And then, of course, you know these schemes, you know these different graphs which has been made on showing the types of neurogenic bladder, very spastic, both sphincter and bladder in high lesions, completely flaccid, incomplete low lesions. That's fine, but really, except from me, it is different in every individual patient. Okay? This is a nice schedule, but it doesn't prove anything, okay, unless you have seen it happen. So what are we going to do? Easily, we're going to do clinical neurological examination. And I'm very happy with your talk, okay? And I heard it mentioning already, okay, here before. Sometimes not so well educated colleagues come and say, well, I have a patient with a spinal cord lesion, but fortunately there is no deficit. And then you say, how there is no deficit? Well, he or she can move her toes. Okay. But there's a lot going on between the legs. Okay? And if you don't go look between the legs, you actually have not done your job properly. And there are the specific bladder-related reflexes. There are the sensations. They all correspond with different parts of the peripheral innervation. And there is, of course, the squeezing of the anus voluntarily, not by reflex. And this can tell you in 70% what's going to happen in this bladder. 70%, not 100%. So it is actually not enough, I think, in some cases, in most cases, to completely determine what you're going to do, because in more than 25%, your information is too incomplete or uncertain. It's not that you make a clinical mistake if you don't go look for further information, but it's also limit your possibility of the most optimal outcome, and that is better. So you need a little bit more. And it doesn't have to be very difficult. You have the history, okay, you have the clinical examination, we've seen it. You definitely have to have laboratory tests like blood tests and urine tests, and then you have urodynamics. And there is urodynamic testing, or the measurement of what happens with the pressure in the bladder during filling and voiding, is extremely important. Frightens some people, say, oh gosh, this is for specialists, this is for urologists. Don't fool yourself. There are not enough urologists in the world to take up this testing, okay? So it will be your task, unless that you find a very dedicated urologist who want to take it up. But urologists just don't have the time and are much more interested in prostate cancer. That's how it is, okay? So you will have to do it. Does it need to be a physician? It doesn't have to be a physician. Can it be an allied professional? For instance, my urodynamic technician is a physiotherapist, okay? And she does it well. And I'm looking over her shoulder, okay, telling her what she has to do, which is a very good collaboration. Available urological test, urodynamic test is that one, okay? Cost price, $1 per session. Many, when they start doing this or have not started this, are more likely to go for this machine. Okay? Such machine is between 16,000 and 20,000 euro per machine, okay? And $3-4 per session. But it's nice, okay? It's a really nice tool if you know how to do it, because it's much more complicated and the danger of misjudgment is much higher. And then you have other things like, I'm just going to mention it, like imaging and so on and so on. If you have an endoscopy urologist, that's fine. How do you have to do it? Well, you have to do your first testing, if possible, in 4 weeks to 2 months after your lesion. You have to redo it when it's indicated. Normally, it takes about half an hour, including positioning, okay? And you have to try to find a place where it's easy to access. And that's what makes video urodynamics so difficult, because there you have to snitch away working time from the radiologist. During follow-up, it used to be that people said, you have to do it every year. That's been abandoned. It's not necessary every year, okay? It depends on how the patient goes. How you have to do it, it's been well described in literature. And then there are other specific tests I'm not going to really develop further on it, like bedside, ice water testing, and so on and so on. If you're interested, if you're very specialized, you can do it. But now you have much more diagnosis, and now you can move to management and the decision there. And this is all list of conservative management. What do you want to go? Triggered voiding, tap, 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 tap. are pushing, whoop, okay, we abandoned it because it has been proven dangerous unless you have a very specific patient where it has no danger. So you need a very proper way to do it. Intermittent catheterization has been the biggest achievement in urological management in the 20th century, and still it continues to be quite popular. It is okay. It's easy. It is not time-consuming if you do it properly. It can be done cheap if you find the proper material. You don't need 5 or 6 times a day a catheter of $3 a piece. Okay? If you have the money, why don't you use it? Okay? Why drive with a motor car instead of driving on a dodo? No? So you see, that's the possibility. But if you don't have it, don't be afraid that you cannot actually do it. And the outcome is good, but you need to follow them. It's not that you give the key to an eternal security. And you see, if you follow patients on intermittent catheterization from 5, 10 to 15 years, that you will see complications, most of them in the urethral canal, but in a very reasonable incidence, which is lower than 20% in 15 years. So it's acceptable, okay? But no complications is not true. Another thing that you will need is drugs. As most of the cases are spastic bladders, you need to lower the pressure, and therefore you need bladder-relaxing drugs, antimuscarinics, and that can be tricky because only part of these medications are available in quite some countries around the world. One drug, oxybutynin, is still available in many places, but they are new, and if possible and if affordable, you can do it. Botulinum toxin, I will come back later. Electrical stimulation, yes, if you have the money to do it and the time to do it. The cost-benefit is uncertain. It can help, especially in electrical neuromodulation. And you might have heard that some groups are looking into implanting, okay, a neuromodulator, so an electrical stimulation thing, during spinal shock. Both sides, costing about 25,000 euros, okay? Because they find in pilot studies that actually it gives a much better outcome in bladder evolution and bowel evolution. But that's fine. But I don't think for most of us still available. Is it necessary to operate? Yes, but if conservative treatment fails, and you see here different things on the urethra, artificial sphincter, stoma, catheterizable stoma, and botulinum toxin. Botulinum toxin, it's become under the push of the company that actually has the product extremely important, and so it has been doing in many places, not cheap anymore. What is the follow-up? Lifelong. How regularly? Once per year to every 2 years, you try to. Many patients do not agree with it and don't come. Or if you have a complication. What will be our future? The future, like for everything, is that we can restore the function by nerve transplants, that perhaps stem cells do work. I can honestly tell you, today, there is no cure. And one must be brave enough and honest enough to tell the patient if they say, okay, well, there is this person who says, okay, I will inject stem cells and you will jump out and you will be completely happy. You said, that's fraud. Okay? That is not true. This is to get your money out of your pocket. Okay? So don't do it. That's our plan now. Doesn't mean that it is a bad treatment perhaps in 10, 20 years, but today, no, it is not for general practice. So now, developing countries. For developing countries, I have, or it has been mentioned, been very fortunate for the last 20 years to work in countries where there was no spinal cord injury care and help to build it up from scratch. And it's extremely interesting to see how much can be achieved with fairly little means. But it must be comprehensive. And it must be multidisciplinary, or you don't do it well. But education of doctors, staff, and patients is of first-level importance. Okay? And if you can, from the beginning, create a spinal center where you bring these patients together in a very highly specialized care, it just is better and it just is cheaper. Okay? And to convince health authorities and the public of it is important. So what can we do if there is in developing country and problems? Train and educate. We can optimize the policy on catheters, on drugs and appliances. We can try to get the people start with hemodynamic investigation and try to start it simple, okay, easy to do, and then, of course, improve the interest of medical colleagues. We can conclude that urinary problems are now less dangerous than in the 1950s, but still very much influencing quality of life and health-related cost. That again, for the bladder management, it must be comprehensive and cross-disciplinary, optimal from day one. It's not say, okay, on critical care, just do what you like and then we will take them. It's too late. And it should not be expensive. Thank you for your attention.
So thank you, Professor Vindale. Is there any question for on bladder management? No? Yes, Sunanda.
How are you going to differentiate between the for a patient to have a suprapubic catheter?
It's just a choice. Okay, you say suprapubic catheters. There are two indications. First, in the acute stage, and that is just in your policy, okay, of the critical care and the acute care. In the long run, because some patients will not be able to be without a catheter, I would advocate using it instead of transurethral, if you can pay for it, okay, and if you can care for it, because it has to be replaced and rechanged. So it is a system that you put into place, okay? Related to expense, the first one is expensive. If you have done it well, if you have taken it wide enough, caliber catheter, to rechange them, it's just the price of your catheter, because you don't need any specific equipment for that. So I will do it, usually, in all those that need an indwelling catheter.
Thank you.
Okay. Yes?
Yes.
Given that you've got a wide group here, I just wondered what happens in the Mauritian context, because this is such an important topic. Oh, sorry. Given that we've got a very wide group here, I wonder what happens
Do you do it?
in terms of the Mauritian context in terms of bladder management. Does any of these things happen? If so, how do you envisage it happening?
Who would like to answer the question among the Mauritian doctors or nurses, or? Yes?
Well, I'm Dr. Ribari from Flack Hospital. So therefore, for most of our patients, we teach them self-catheterization. Most of them we teach those who want to learn or those who are quadriplegic, that is tetraplegia. So we ask one of the relatives. This is what I used to do with my patients. Because I do mostly spine surgery, so with those with that is spinal cord injuries with quadriplegia, we have to involve the relatives also in the management of the patient. This is how we do it. But some patients stay with indwelling catheters for a long time. They come to the hospital quite about 2 weeks or 1 month to have it changed in the hospital itself.
Okay. Do you easily get intermittent catheters? Because we saw 2 patients yesterday who were telling us that they can't get hold of catheters for intermittent catheters.
Yeah, all depends on the hospital you work. All depends. In Mauritius, it's a bit Because we have surgeons coming from different countries, we don't have a protocol, in fact. So it depends how you are trained, how you can give the maximum to the patient. But at Flack Hospital, and previously as I was at the JNH, that is Nehru Hospital, this is what was done. Patients were getting the catheters. All depends on the system. I don't know what about other hospitals. Maybe they can add to it.
Sue?
A patient doing self-intermittent catheterization, as in 4 times a day.
Yeah.
So
Yeah.
you can get catheters in.
Yes, we do. We do provide them. Yeah.
And are they available through a public health scheme, or does the patient have to buy them privately?
Now, most of the patients, when they come to the outpatient, they have at least one review every month or every 2 months. As long as I am in that outpatient, they are provided with. They are given.
So they have to come to the hospital
People, yeah, to get it.
They can't just order them through the pharmacy.
Now it becomes a bit difficult because it's only in the outpatient at the hospital, which is a bit central part. So they get these catheters.
I'm a bit surprised.
Yeah.
Yes.
I would have thought that it would be easily to buy them in a pharmacy or something, no?
Some patients do those in the private practice.
Yeah. We have done just a study with Dr. Shabra from Delhi looking into can a patient safely reuse a catheter, okay? So the basic catheter, can he or she reuse it? And actually you can for a week or longer, okay? So then the price is becoming really very low.
Much less, yeah.
I have been told that if there are not 3 questions more, there is no lunch.
So, there's another question then.
I'm Dr. Chanu, orthopedic surgeon. We have had cases of spinal injury where there has been dysfunction of the bladder. But I saw that you have been doing this manometer test. We have been doing it as well. At first, probably we have put the catheter, catheterized the patient, but eventually teaching the patient, doing physiotherapy, having patients, relatives to come and help the patient, we have seen that the pressure in the bladder has increased. So this can be monitored by this water manometer. And I think this is a very good test that should be done from time to time. Thank you.
Well, I agree. No.
Okay, Dr. Washington? That's good. Yeah, we get there.
Just a comment, because to fill the sort out the lunch, that's why I'm getting into it, so people get lunch. I'm a very kind-hearted man. Right, in terms of management of bladder, I appreciate wonderful talk about the bladder management, but there are, from rehabilitation point of view, there are other factors that have to be considered, and one of those are the sort of spasticity, which can cause the barrier, the pain. With intermittent self-catheterization can cause a difficulty with people having problems with the hip pains and stuff. So it's a kind of multidisciplinary approach that is required with the physical therapist, with occupational therapist, and the rehab physician or the spinal doctors. That you have to modify the spasticity, you have to manage the adductor spasticity, in particular perineal hygiene, teaching, and all the rest of it, because just not having a clean catheter is not a guarantee for not introducing infection. It is also about the perineal hygiene. So these are three things that we actually worked very hard on in Abu Dhabi, and we have a very decent setup now whereby people are not frightened of using the intermittent catheterization techniques anymore. There's one barrier to it, and there is a cultural barrier. People don't like, it's much easier to just have an indwelling catheter, so you have to educate patients that, you know, this is much better for you in terms of longer term management from renal point of view, and also the issue of teaching the people the techniques as well as beside just doing the catheterization. That's just a comment.
Sure. Okay.
Thank you.
Thank you.
Thank you. Now, do you think that they deserve the lunch then?